Hey everybody, thanks for taking the time to join us today to review value-based care and how it might be able to benefit you. We apologize for getting started a couple minutes late, technical difficulties, and now we're ready to go ahead and kick off. I am the Chief Commercial Officer here at CareOptimize. We've been providing solutions, both software and services, for medical practices and medical organizations, hoping to succeed in value-based care for about the past 10 years. Jumping into the agenda, today we're going to cover what exactly is value-based care. I know it's a commonly referred to acronym and or buzzword, but we're going to break it down a little bit more. We'll discuss bearing risk, what that entails and how it can be done. We're also going to review some of the technology solutions that CareOptimize is offering its potential partners in order to succeed. And then we do have a users group meeting giveaway that was recently offered to anybody who participated in the Next Gen Users Group meeting, but also is going to be offered to anybody participating on the Insights call. Moving forward, essentially value-based care is the process of aligning healthcare and coordinated delivery goals to reduce costs, reduce utilization, and improve quality. The overarching goal is to get the patient the care that they need and to not utilize additional hospitalizations, and at the same time making sure that we're adhering to all the different quality aspects that go into providing care for a patient. One of the things that we like to regard is that value-based care puts a strong emphasis on quality over quantity. So we want to make sure, once again, we're offering the best care, not just sending as many patients in and out as we can. How does it work? Value-based care, rather than being paid for each service, a payment is provided based off of quality and efficacy of care. So we're going to adjust the payments or the payer relationships that providers are in. We'll adjust payments based off the quality offered. Other terms that you'll hear used to describe value-based arrangements are, full risk, partial risk, capitation, pay for performance, pay for value, value-based care, ACO, bundled payments. These are some of the popular terms used to describe risk-adjusted models where value is the underlying determinant of the outcome. Typically, we see primary care participating the most. We've also seen some very large specialty groups participating in these types of arrangements, as well as FQHCs and CHCs. A couple of the different models that might be familiar to you at your practice or your medical organization are the Medicare Advantage models, managed Medicaid, depending on which state you're in, or participation in an accountable care organization. The first and most prominent model that we see is going to be within Medicare Advantage. Back in 1999, CMS introduced the opportunity for private payers to begin rendering Medicare services and stewarding the Medicare plans for patients. Patients are able to assign their benefits to a company like Humana, and then Humana will steward the claims process, the payment of all the claims, the management of the care for those patients. The model's been growing rapidly since it came in its inception. About 34% of Medicare beneficiaries are in a Medicare Advantage program of some way. It's also predicted that about 48%, or almost half, of all Medicare patients will be in an Advantage plan by 2028. We do see consistent evidence showing the rapid growth of Medicare Advantage throughout the past roughly 17, 18 years. As you can see, starting in 2004, we have not had any decline in beneficiary membership growth over much further than a decade. So we're looking at 14 years, year over year. The participation levels for Medicare Advantage are constantly improving, and it's growing rapidly. At 2020, we're at about 36% of all Medicare beneficiaries. Across the country, in the red, you're going to see large breakdowns or large concentrations of Medicare Advantage patients or plans. Dark blue is going to be about 31 to 40%, light blue, so on and so forth. What is made clear from this map is that unless you live in Alaska, Medicare Advantage is growing in your area. Alaska, as we can see, is the only state that doesn't have adoption. Managed Medicaid is one of the other value-based reimbursement models we're going to be talking about. Essentially, Medicaid has contracted with private organizations to offer Medicaid at a capitated cost. 32 states have privatized Medicaid, and risk scores or risk-adjusted models are used to determine premiums. Across the country, you see, I think it's about just over half, except for the Southeast United States, we see high adoption of the Medicaid expansion and the privatization of the Medicaid, managed Medicaid plans. Accountable care organizations, a lot of people have been growing more familiar with ACOs. Back in 2011, started with about 32 different ACOs across the country. These organizations really pioneered integrating care delivery and connecting with hospitals, specialists, other affiliated providers to manage the risk and the costs that are invested into their patient populations. Accurate risk adjustment in an ACO is the best way to find or generate new savings. And if you don't know, with an ACO, the amount of savings that are generated then equal the amount of shared savings that's distributed amongst the members of the ACO. Today, we have almost 650 of them across the country. So the model's been, as you can see, growing rapidly, similar to Medicare Advantage, which is another one of the value-based arrangements we just discussed. The ACO arrangements, which will be more focused on Medicare Part B patients, are also growing at a consistent rate. As we see more ACOs popping up, we are seeing more ACO lives covered, which is highlighted by the orange line through the graph. So participating in any of these different risk-based models is kind of tough. It's a new way of practicing medicine, and most people from the traditional fee-for-service world aren't really prepared for it. So in order to be successful in any sort of value-based reimbursement, we're going to need to deploy new technology. You'll want to leverage expertise from different organizations that have experience and success within these models. We will need to deploy additional financial resources, and in some cases, it's not uncommon for the administration to have an entire medical economics department, which will support the efforts in value-based care. Many providers are just trying to keep their practices open these days, and getting deeper into taking risk and exploring what that financial burden might mean for their overall success is kind of intimidating, in my opinion, and many of the providers we work with's opinion. We don't want to have to overhaul the entire infrastructure just trying to get started. So partnering with a company that can help you do that is going to be one of the ways to drive home success. So part of participating in any risk-based model or value-based care model is going to be the actual financial component, the risk-bearing entity, or as we refer to on this slide, the RBE. This is an organization that assumes financial responsibility for the provision of a defined set of benefits by accepting prepayment for some or all of the cost of care, i.e. this can be an MSO, it can be the ACO, it can be whichever entity in the population health paradigm or value-based care paradigm is actually bearing the financial risk for the expenditures of its patients. There are a couple trends we've been seeing in 2020 with respect to value-based care and its adoption. We've noticed that capitation has become a much more attractive means of financial compensation for providers. Throughout COVID, we saw significant dips in the ability for patients to come in and actually generate a fee-for-service encounter. If you don't see the patient, then you aren't necessarily able to bill for seeing that patient, and that has a negative impact on practices' revenue. At the same time, within COVID, in order to combat this particular dip in revenue, telemedicine was expanded on. Medicare started paying for services that they previously hadn't. The beautiful part about that is conducting telemedicine encounters are less expensive ways of actually seeing a patient, and they fit into a value-based delivery system very well. Home care became incredibly important. Remote patient monitoring, home visits, home health, actually going out to meet the patients where they're at and provide the care where they need it was actually demonstrated to have a lot of impact on treating COVID patients, etc. But providing patients care in the comfort of their own home is kind of how everybody would see the future rolling out in a value-based system. Medicare continues to march towards risk despite temporary delay in the full implementation of MIPS. We're seeing it stay the course, 9% plus or minus on your Medicare Part B reimbursements is the payment adjustment for 2021, and that has not been changed or taken away. So as we can see, Medicare is slowly starting to implement value-based adjustments or risk-based adjustments within the Part B fee-for-service world. And then it continues to be a challenge to take on risk, although we see all this evidence pushing us towards the fact that we need to do this to keep our financial stability, as well as give our patients the quality of care that they deserve. It's still a big lift. It requires significant medical management staff, once again, population health systems, and financial wherewithal, as plans continue to push providers to some form of downside risk. A couple different arrangements do enable providers to only reap the benefits of upside risk. However, it is preferred by the plan that they take upside and downside risk, which will encourage, more cost sharing, etc. CareOptimize was founded in 2015. We like to consider ourselves experts within the value-based care paradigm. We provide people, processes, and unique technology that ease the switch. Taking what was once a fee-for-service world and then shaking that up to realign capitation, surpluses, etc. It just requires a lot of extra work. We do have the people and technology that can facilitate this transition for your practice and transform to a value-based reimbursement model and successfully do so. Outlining our solutions, CareOptimize sits in the middle. We do provide aggregation and AI technology that takes data from multiple sources. A lot of what we have available for us during a patient encounter is coming from their chart or their EHR. We also want to be able to look for data that's going to be significant to how I make a decision on my patient or what types of care or treatments I render or provide based on what's happening with their health plan, based off of best practice guidelines. There are also health information exchanges, eligibility data, hospital data, registry data, prescriptions data that's available to incorporate all into one place. What CareOptimize then does is it predicts and determines where there's gaps in care and where additional quality items could be rendered. This all happens simultaneously as you're practicing medicine, and then the information or the notifications are delivered to providers at the point of care within their EHR. This makes it so you don't have to hunt down a bunch of information. You can actually simply go through a patient encounter, when and where the value-based items that need to be addressed are needed. Maybe at the end of your SOAP note, they're quickly addressed, pop up for you. You can acknowledge them, make a comprehensive chart note, and then move on, all with the help of autonomous technology working behind the scenes for you through CareOptimize. Quality and coding gaps in care are the two modules that we are offering today. We do have a lot on the horizon, which we'll be excited to share with you in the future. But what we think is the most important for anybody getting started or looking to maximize the value of the risk-adjusted arrangements that they're in is making sure that the quality and coding gaps are filled. So once again, we aggregate the data across the healthcare continuum. This helps compile a unified patient record, curate care, quality measures, coding gaps to the physician based on the individual funding requirements, providers or the funders, direct insights into the gap closure rather than relying on the currently inadequate and burdensome data exchange. We give transparency into the direct connections of the plans. So what's been going on, this could be an example where a patient received a flu vaccination at Walgreens, but it wasn't incorporated into their medical record. Things of that nature do need to be taken into consideration when completing all the quality efforts that we have. When you're participating in a value-based program, tracking your performance becomes paramount. We want to make sure that as we're going through the year, we're constantly looking at how the health plan and or whatever payer we're working with is grading us. That will then help us determine how our finances are going to work in the future moving forward. Also, having the ability to drill down to health plan practice and patient levels expose unique gaps at a granular level that we can quickly dust off or complete and close. And then identifying these quality and coding gaps becomes cumbersome. If you look at things like MIPS or HEDIS or Joint Commission, Medicare Shared Savings Programs, which ACOs fall under, the quality metrics that need to be adhered towards are constantly updated and changed. So it becomes confusing, when you're a provider seeing a patient, you're thinking about how to help them with their problem today. You're not necessarily wanting to acknowledge, oh, this patient could meet one of 200 different possible metrics or more, could meet 10 of those 200 possible metrics, and then go check those boxes for you. Having a tool like CareOptimize to analyze each one of these different metrics, determine which ones are needed for that specific patient, and then keep track of all the updates that come year over year is very imperative to being successful. The quality module, as you can see, we have a screenshot here. Some of the different metrics that I'm referencing throughout the slideshow, things like controlling high blood pressure, screening for osteoporosis for women of 65 to 85 years old, pneumonia vaccines, documentation of current meds, diabetes. These are things that you've been seeing throughout meaningful use, throughout PQRS, and in the subsequent quality adjusted programs that Medicare continues to invest in. But there's a lot of them is what we're hoping to show on this slide. And just knowing where you lie and where you can improve upon is going to help you make so much more of an efficient visit, and also improve your financial outcomes as well. The coding module. This module predicts where evidence might support an additional HCC code or ICD-10 code to be added. A common example is if a patient has a certain HbA1c result and diabetes is not documented within their chart, we just don't want to forget to add the ICD-10 code. It's very important that during the provider visit with the patient, these codes are added during the encounter. And thinking about everything and reviewing all the labs and going through it becomes a bit of a challenge, and it's a massive cognitive load on somebody who's already trying to solve a patient's health condition. So making sure that we enable coders and or providers to see areas that are supported by evidence within the system enables you guys to capture all the different codes that might pertain to the patient's diagnostic situation or chronic conditions, put them in there, and quickly view the supporting evidence that needs to be incorporated to quantify this code.